Am I audible? You can type in the chat box. Audible? Okay. Hi everyone, I'm Dr. Sarah Sheikh. I am very thrilled to conduct this session for MedPrep Online for all of you students who are budding MRCOG aspirants. I'm MBBS MS OBGY from JJ Hospital, Mumbai, and I'm currently working as a consultant in Mumbai. So let's begin this topic. It's a webinar, but it's more of an interactive session. I want all of you to post your doubts, ask your questions, and interact in this session. So it will be an insightful lecture for you on how to study, how to prepare for MRCOG. The topic I've selected for today is adrenal gland disorders. It's a very important topic from endocrinology point of view. You do get 2 or 3 questions, which are mostly clinical case scenarios. So once you understand the concept, it will be easy for you to answer all of the questions, hopefully. So let's begin. Now, as we all know, the basic anatomy of adrenal glands, these are 2 paired structures, right? Triangular shaped structures, which are sitting on top of both of your kidneys, correct? So the left being higher than the right. Now, it's always a favorite of the RCOG to ask the blood supply, the venous drainage. So here in this session, we've combined everything in one place. We've curated all the information for you from very high quality sources. So hopefully you should not have any problem to answer questions related to this topic. Now the blood supply, again, you don't have to mug anything up. We try to solve everything by our concepts as much as we can. And so yeah, let's see. Inferior phrenic, because we know it's as close to the diaphragm as possible. Next is renal artery, as it's sitting on top of the kidney, and one of direct branches from the aorta. Correct? Now, venous drainage, it's the same way as it's peculiar for the ovarian vein. On the right side, it will drain directly into the IVC. On the left side, it drains with the left renal vein. Now, lymphatics, because of the position, as we know, the adrenal glands are located in the lumbar area. The drainage is directly to the lumbar nodes. Now, adrenal cortex. So, microscopically, the adrenal gland is divided into 2 zones, correct? There's the cortex and the medulla. So, this we know from anatomy. But also, this distinction is embryological because the cortex, it's been derived from the coelomic epithelium. But the medulla, again, it's from the enterochromatin tissue. Basically, it's a neural crest derivative. And again, this is one of the favorite RQG questions. What are the neural crest derivatives, or where is the adrenal medulla derived from? Okay, so now adrenal cortex, I've written GFR here. If anyone from the session can tell me what GFR stands for? Anyone in the chat box?
Glomerular filtration rate.
It's a mnemonic. Let me give you a clue. You know from the sessions that I've conducted so far, I'm all for mnemonics and diagrams, whatever simplifies your learning. It's part of the cortex.
Good fried rice.
No. Okay, another way to remember it. But basically, yeah. Yeah, correct. So you remember it as GFR, well, like you rightly said, glomerular filtration rate. So that's one way to remember it. And it's divided into 3 zones, correct? It's glomerulosa, fasciculata, and reticularis. So once I show you this picture, I think you'll have more clarity. Now we can see the cortex is divided into glomerulosa, fasciculata, and reticularis. Now each of these zones will secrete a specific hormone. So you have the corresponding hormones mentioned here on the diagram. So you have mineralocorticoids, you have glucocorticoids, and adrenal androgens. For me, how I remember it, salt, this is sugar, and sex. Okay, so don't judge me. This is my mnemonic. Whatever you find easiest to remember from your MBBS days, from your medical days, do that. Whatever floats your boat. So salt, sugar, and sex. S3. So that's how you correlate these questions. Okay. Now the next. Now the medulla. Now medulla, as we saw, is a distinct zone even embryologically. And why it's clinically important? It secretes the most important chemicals, which are catecholamines. So these are epinephrine and norepinephrine. Fine. We'll see the clinical significance of these later. Now, all of these are cholesterol derivatives, and most of them are protein bound. Now, cortisol, which is the main hormone, it's mostly bound to albumin in the form of transportin, and aldosterone is only 50% bound. In glucocorticoids, the secretion of cortisol to corticosterone is 1:17, but the more potent form is cortisol. Most of the functions that occur in the body are because of the effect of cortisol. These are metabolized in the liver. They are mostly conjugated to glucuronides, to a lesser extent to sulfates, and are excreted in urine and bile. Now, how do you remember the hormonal control? Just concentrate on this diagram. These are under hypothalamic control. So the median eminence of the hypothalamus, it will receive neural signals, and in response to that, it will release corticotrophin releasing hormone. Now this corticotrophin releasing hormone, it goes and acts on the anterior lobe of the pituitary. Now in response to that, there is secretion of ACTH. Now this ACTH will go to the adrenal gland, and in response, the cortex and the medulla, cortex mainly, will secrete the hormones of cortisol, aldosterone, and androgen, correct? Now, out of these, as we all know, most of the cycles have a negative feedback. So the negative feedback to ACTH comes from cortisol, not from androgen, not from aldosterone. This is a very important key point to remember. The cortisol has an inhibitory action on ACTH secretion. Now, in the other diagram, it's the same thing. It's just been broken down. The secretion of ACTH is not as simple. It's first secreted as pro-opiomelanocortin, which is POMC, which is again processed. It's basically undergoing cleavage and hydrolysis to form a pro-alpha melanotropin as well as ACTH. This ACTH in turn will stimulate the cortex and produce the respective hormones. Now, what are the physiological changes which are seen in pregnancy? As we know, in pregnancy, it's a condition of stress, correct? So to deal with all of the stress and changes that are occurring in the body, there is an increased secretion of cortisol. There's also an increase in all the proteins. So along with that, there is an increase in cortisol binding globulin that makes the half-life more. So there is increased effect of steroid hormones in the body during pregnancy. Another source of cortisol or another source of steroid hormones is because of the placental production of CRH. Corticotrophin releasing hormone is also produced by the placenta. So in pregnancy, it is physiological to find mild adrenal hypertrophy. And another very important clinical point is that there will be an increased response to ACTH administration. Now, why this becomes clinically significant, we'll see later when we do the test called synaptin test to test for insufficiency. This response is fallacious. You will not find a very adequate response. So you cannot use this test in pregnancy. Now, ACTH itself is a polypeptide made up of 4,500 daltons. And as we know, it increases in conditions of stress, correct? So diseases as well as pregnancy. We saw it is regulated by the hypothalamic circadian rhythm. And we know ACTH to be secreted. We know cortisol gets secreted maximum in the morning, right? So immediately before waking up, that is when the cortisol is at the highest. Throughout the night, it is secreted in bursts, and the maximum is on waking up in the morning, and the lowest is at midnight. So we saw again the negative feedback is only by glucocorticoids. That is only cortisol. It won't be aldosterone. It won't be androgen, correct? Now the next hormone is androgen, aldosterone. Now aldosterone, we know, it acts basically on DCT as well as the collecting ducts. That is where the main action of aldosterone lies, as well as it acts in the posterior pituitary to release ADH. Now, both of these functions, acting on the DCT as well as ADH. ADH we know is antidiuretic hormone. So what do you think the net effect of this is going to be? Anyone can unmute themselves and answer. What is going to be the net effect or action of aldosterone on the body?
It can lead to increase in volume, the circulatory volume, because of
Correct.
its antidiuretic effect. Plus, as it acts on DCT, so it will also cause reabsorption of sodium and put in the DCT and collecting ducts. So that will further increase in total circulating volume.
Correct. Perfect. So you have sodium, and whenever sodium is increased, along with it, it pulls water. So that's absolutely right. That's going to increase the intravascular volume, correct? So this is the main action of aldosterone. So here, aldosterone regulation is not under direct ACTH control. It comes under renin-angiotensin-aldosterone system. So whenever your kidney is sensing a drop in blood pressure, what it does, it releases renin. Now, renin basically where it's stored It is stored in the JG apparatus, juxtaglomerular cells, which are basically specialized cells which are present in afferent and efferent arterioles in the kidney. So once renin is released, it acts as angiotensinogen. Now, angiotensinogen is converted to angiotensin 1. Now, this angiotensin 1 is acted by something called as ACE. ACE is angiotensin converting enzyme. This is present in the lungs. So once this is released, angiotensin 1 is converted to angiotensin 2, which is a potent vasoconstrictor, because of which the net effect will be there's an increase in blood pressure. This angiotensin 2 also activates aldosterone. Now, aldosterone we just saw, it holds on to water as well as sodium, but what is the net effect? When you have one positive charge coming in, you have loss of potassium. So you have loss of potassium leading to hypokalemia. So you have sodium retention as well as blood pressure will increase. So aldosterone regulation, the most important factor which causes the secretion, when you have to pick between options, it's always increase in serum potassium. So any increase, excessive increase in serum potassium in ECF will lead to secretion of aldosterone and its excretion. Again, if there's decrease in serum sodium in the ECF, if there is any condition which is causing decrease in ECF volume, like you rightly said, if there's any blood loss, acute blood loss, if there's hypovolemia, there's hypotension, if there are burns, hematemesis, correct? And obviously now, according to this, we can determine what will be the negative feedback. It will be inhibited if there is an increased intake of sodium or in cases of hypertension. Now coming to glucocorticoids. Now glucocorticoids, once we understand its role, its functions, we'll be able to understand the clinical significance and why we use it in our day-to-day practice. It's anti-inflammatory and it's affecting the immunity. Now, its most important use in clinical practice is as an anti-inflammatory drug. Why is it given? Because it stabilizes your mast cell membrane, it stabilizes your lysosomes, so it has an anti-inflammatory action. Then what it does is it leads to gluconeogenesis and it inhibits the uptake, correct, of glucose. So the net effect will be increased in blood sugar level. So can someone tell me what is the clinical significance of this in our practice? Specifically related to obstetrics. What happens when you give steroid to a mother?
So it causes increase in the blood sugar level. Whenever we give dexamethasone or betamethasone for fetal lung maturity, in a diabetic women, we adjust the dose of insulin because the glucocorticoids are known to cause derangement in the sugar level or they increase the blood sugar level.
Correct, perfect. So you do an extra monitoring, you may have to give up top-up doses of insulin when a patient, already a diabetic patient, is receiving a steroid cover, correct? Now, what it does is it causes protein catabolism. So this will lead to muscular wasting, correct? Muscle wasting, and there will be negative nitrogen balance. So there will be increased amino acid in the plasma, but along with that, there is increased protein in the liver. So there is only catabolism in the plasma, but there is increased protein synthesis in the liver. It also leads to lipolysis, which will cause a ketogenic effect. Now, glucocorticoids, apart from these functions, they do have a very mild mineralocorticoid action. So this leads to slight sodium and water retention, which is not very significant, not as the effect of aldosterone, but it does cause sodium and water retention. It causes fetal maturation. How? By basically maturing the type 2 to type 1 pneumocytes, and this will lead to the release of surfactant. This is why glucocorticoids are given for fetal lung maturation during your antenatal period. It also causes osteoclastic bone resorption. So it causes osteoporosis and it has the propensity to cause osteoporosis and fractures. Now, the sex steroids are the simplest of the lot. All you have to remember are 3 hormones, DHEA, its sulfated conjugate, which is DHEAS, as well as androstenedione. Estrogens and testosterone, very mild form. Now, in males, these sex steroids will be secreted from the age of 7 to 9 years. In females, it will be secreted from the age of 6 to 7 years. And it has more important function in females. For males, these do not form the most significant source of androgens, but for females, this is a major source of androgen. And it is required basically at the time of puberty as well as menarche. It maintains the libido as well as the muscle mass. Now, catecholamine synthesis. Now, we've finished the cortex, we've come to the medulla. Now, catecholamine synthesis, what is the stimulus? The stimulus will be from the cholinergic sympathetic nerves. And the release of catecholamines is controlled by the posterior hypothalamus as well as acetylcholinesterase release. As we know, all the catecholamines, they have a short T-half lasting only for 1 to 2 minutes. Now, how are they formed? You don't have to remember all of the enzymes, just remember the major conversion and byproduct. So from the medulla, all of these enzymes are present in the medulla. L-tyrosine is acted upon by tyrosine hydroxylase, which forms DOPA. DOPA decarboxylase will form dopamine. Dopamine hydroxylase will form norepinephrine. Now, norepinephrine, again, it undergoes degradation by COMT pathway to form the metabolite normetanephrine. And norepinephrine itself undergoes conversion by phenylethanolamine methyltransferase, and it will form epinephrine. So these are the two byproducts of this pathway. Now, always remember, adrenaline or epinephrine, it acts both on alpha as well as beta receptors, whereas noradrenaline, it acts only on alpha receptors. And fetal catecholamine, the major form of fetal catecholamine is L-DOPA. Okay. Another interesting thing you would want to know about adrenaline and noradrenaline are basically the functions. So they act via G protein coupled receptors, and we know they play an important role in fight, flight, or fear response. Correct? Now, metabolism, we saw that it is either monoamine oxidase or it is catechol O methyltransferase pathway. And these products are excreted in urine. You will see the significance of this when we study pheochromocytoma. Now, as we all know, when we talk about fight, flight, fear response, all of the effects which occur in the cardiovascular system, there'll be increased heart rate, increased stroke volume, there'll be increase in blood pressure. They have a mild salt and water balance retention. They have bronchial dilatation effect, GIT relaxation. It causes lipolysis, again, glycogenolysis, so increases in the blood sugar level. It reduces the blood flow to the splanchnic circulation, increases the blood flow to skeletal muscles. Okay, this is an important point to remember. And one effect of norepinephrine is it is antagonistic to the effect of adrenaline. On injection, it causes reflex slowing of heart rate. Okay, so this is one peculiar effect that you have to remember for norepinephrine. Now let's come to the disorders. Pathological disorders, these are Cushing syndrome, Addison's disease, primary aldosteronism, which is also called as Conn syndrome. You have congenital adrenal hyperplasia and pheochromocytoma. Now Cushing's. So we have a lot of debate, or rather we have a lot of confusion with regards to what is disease and what is syndrome. So once and for all, let's just clear it. Disease is whenever there is a pituitary erosion. So if there is a pituitary neoplasm, this is classified as Cushing's disease. So here you have basically pituitary microadenomas or macroadenomas, correct? Now for syndrome is whenever you have the source of the steroids or the source of cortisol is basically from the adrenal. So adrenal erosion, this could be adrenal adenoma, it could be ectopic hormone production, or it could be iatrogenic. Now, can someone tell me what is the most important cause for Cushing syndrome? Out of all of these, what is the most important and the most commonly seen?
Iatrogenic. Outside.
Correct. So, iatrogenic. That's basically when you are giving or you are supplementing the patient with steroid hormones, maybe to treat any chronic inflammatory conditions or for prolonged usage. Correct? And out of adrenal, the most common is adrenal adenomas. Now, this is a very important and I think very useful diagram, which will show you all the effects and all the symptoms of Cushing syndrome. So as we saw, syndrome, the most common cause is adrenal adenomas. This is when it comes to adrenal pathology. So don't get confused. Overall, it is iatrogenic. And it can also present with hypokalemia and metabolic acidosis. We'll see why. In females, it is a cause of amenorrhea and infertility. So when you do get patients in the clinic, this has to be one of the conditions that has to be ruled out if a patient is on prolonged steroid use. Okay, now another syndrome is pseudo-Cushing. Now pseudo-Cushing is basically like the disease, it is of central origin, but it mainly affects the hypothalamus. So hypothalamus has increased corticotrophin releasing hormone, which is seen in conditions like obesity, alcoholism, as well as growth hormone deficiency. Fine. Now in Cushing's disease, since the origin is pituitary and there is a medical problem with the pituitary in terms of an adenoma, there can also be associated loss of other pituitary hormones. The patient may present with coexistent hypogonadism or hypothyroidism or a growth hormone deficiency. Now, Cushing syndrome, now since we know all of the functions of cortisol, we know all the functions of glucocorticoids, you will be able to correlate as to why these occur. So patient will present with hyperglycemia, there'll be CNS irritability, sodium and fluid retention. There'll be one very peculiar characteristic of Cushing syndrome is basically central obesity, and the patient will have thin arms or thin extremities. There'll be increase in GI ulcers. There'll be increased secretion of hydrochloric acid, which will lead to ulcers. So that is why we call it stress ulcers. In females, you will have amenorrhea, hirsutism, thin skin, purple striae, bruises, and fatigue. Now, these are buzzwords. Whenever they want you to diagnose Cushing syndrome, this is what they'll definitely give you in the question. Patient is having thin skin with easy bruising, and purple striae. We saw osteoporosis and fractures, and there'll be a particular characteristic feature, which is a buffalo hump because of the fat deposits on the back. In males, it can lead to gynecomastia. Because it is anti-inflammatory, it increases the susceptibility to infection. It causes moon phase and personality changes. Now, another classification for Cushing syndrome is ACTH dependent and ACTH independent. So let's see ACTH independent. As the name suggests, ACTH is going to be normal. So we know the pathology lies in the adrenal gland. So you could have either iatrogenic with exogenous glucocorticoids, or you could have adrenal neoplasm, or you could have an ectopic hormone production. Now, ACTH dependent is basically there is hypersecretion of ACTH because of an ectopic ACTH production. That means the ACTH is not getting secreted by the pituitary, but rather there is some other pathology in the body which is increasing the secretion of ACTH. Now, that could be a carcinoid, which is a bronchial carcinoid. It could be small cell carcinoma of the lung, pancreatic cancer, medullary cancer of the thyroid, or a pheochromocyte. Now, what's the treatment? Now, treatment or management of Cushing syndrome is basically dependent on the cause. So if it is a pituitary disease, if it is a pituitary microadenoma or macroadenoma, which is amenable to surgery, then transsphenoidal surgery is a surgery of choice. If it is an adrenal adenoma, then adrenalectomy is the treatment of choice. For medical treatment, you have somatostatin analogs, which is pasireotide, and there are some drugs, steroid inhibitors. Now, K-MAM is just the mnemonic for you to memorize them. This is ketoconazole. You have mifepristone. There's a drug called aminoglutamide. And metyrapone. So this constitutes the medical management of Cushing's disease. Now, Addison's disease. Now, Addison's disease is exactly the reverse of Cushing's disease. So, Addison's disease is a chronic primary adrenal deficiency. So, what you mean by primary is the basic defect here lies in the adrenal glands. So, whenever you memorize any condition, there are always certain causes which are common throughout. So, we know it's either trauma or tumor, or there is infection or drugs. The same goes for Addison's disease. Most common cause here would be autoimmune diseases. There is a condition called autoimmune polyendocrinopathy syndrome. You don't have to go into the details. Just remember that it is most commonly seen with APS type 1 and type 2. Infections, tuberculosis and CMV, malignancy, infiltrative disorders like hemochromatosis and sarcoidosis, drugs, as well as rapid withdrawal. Now, why rapid withdrawal is important? Because whenever in our clinical practice, we are treating any inflammatory condition with prolonged course of steroid, any chronic condition which is receiving steroids for a long time, if you withdraw them all of a sudden, what happens is these steroids are suppressing the adrenal gland, correct? So because of sudden withdrawal, the adrenal gland cannot secrete enough of these glucocorticoids, these hormones, because of which a patient can land up in Addison's crisis. So now how do you remember Addison's disease? Because we know the effect of glucocorticoids, now we know what its deficiency can cause, correct? So there'll be hyponatremia, there'll be hypotension, there'll be hypokalemia, there'll be hypoglycemia, and there'll be hyperpigmentation. Now this picture summarizes all of the features that are seen with Addison's disease. You'll have decrease in blood sugar level, hypoglycemia. There'll be postural hypertension because there is loss of sodium as well as loss of water. So postural hypertension as well as dehydration. There is going to be weight loss, loss of appetite. Patient will come with muscle pains, weakness, myopathy. There'll be gastrointestinal disturbances. patient presents with nausea, vomiting, and abdominal pain, there'll be bronze pigmentation of the skin. Now, why does this occur? Can anyone tell me? Why do we have pigmentation in case of Addison's disease? Anyone?
Due to accumulation of melanin?
Yeah, but what is stimulating melanin? What's the basic defect in Addison's disease? We're talking about deficiency. What is deficiency?
Thyroid hormone.
We have deficiency of glucocorticoids, right? And ACTH is under the negative feedback of glucocorticoids. So here you have hypersecretion of ACTH. Now, one peculiar thing about ACTH is that it is analogous to melanocyte stimulating hormone. So because of this, you have bronze pigmentation of the skin, you will have pigmentation in the palmar creases, any old scars. So that is how the patient can present to you. Now, adrenal crisis is something that you have to know, which is when a patient presents with acute adrenal insufficiency, patient will have profound fatigue, there'll be dehydration, there can be vascular collapse, the patient may land up with shock, there can be an acute renal shutdown, and as we know, this is because of decrease in serum sodium, there's decrease in intravascular volume, and there is increase in serum potassium. So you have this diagram, which again, Addison's is self-mnemonic for the disease. It summarizes there's an excess of ACTH, there's autoimmune destruction, which is the most common cause in almost 80%, abdominal pain, nausea, vomiting, and here you use ACTH stimulation test to diagnose it with low cortisol. There'll be stress, the patient will not be able to withstand stress, rather, patient will have salt cravings, dark skin, low sodium, and hyperkalemia, as well as orthostatic hypertension. Now, diagnosis. Biochemical test will show you increase in serum potassium, there'll be loss as well as increase in serum calcium, and there'll be loss of sodium. Confirmatory is by synactin test or tetrafluorosaccharine test, which we'll see later. Now, when we do synactin test, which is basically a synthetic ACTH test, if you get a decrease in cortisol with increase in ACTH, so you know the problem lies with the adrenal, right? So this is a primary adrenal failure. The main pathology lies in the adrenal gland. But if you're getting a result which shows decrease in cortisol as well as decrease in ACTH, this is a secondary adrenal failure. The cause probably lies in the pituitary gland. Now, imaging, you have CT as well as MRI. The size of the adrenal gland, you know it will be decreased in autoimmune diseases, but the size may be increased in infections. Now, treatment, you have to supplement what is not there. So here you have loss of both mineralocorticoids as well as glucocorticoids. So you have to basically supplement with hydrocortisone and fludrocortisone. Now you have tests for adrenal function to differentiate between different types of pathologies. 9-AM cortisol and synactin test, these two are mainly to diagnose insufficiency, is what you have to remember, as well as low-dose DEXA suppression and high-dose DEXA suppression. These are basically to diagnose Cushing's syndrome. So I know it looks like it's a lot to take in, but it's quite easy to understand. You just have to remember the names of the test and which test will be used for which particular disease. Now, as per RCOG, you have to always pick the simplest test, which is the least costly and the most effective. So for insufficiency, you have the 9-AM cortisol. We know the levels peak in the morning, correct? So in adrenal insufficiency, you will be diagnosing it if it is less than 100. If it is more than 400, it is unlikely to be a case of adrenal insufficiency. If there are levels between 100 to 400, you need to confirm it by the synactin test. Now, synactin test is basically, as the name suggests, it is a synthetic ACTH test. What you have to do is you have to measure the cortisol before and after giving the injection. The injection is a dose of 250 micrograms. Now, what will be the normal effect? If ACTH is given to a normal person, there will be an increase in cortisol. Cortisol will get secreted from the adrenals. So normal response will be a cortisol rise after injection. So this test is basically divided into a short test or a long test. In a short test, you just collect the sample after 30 minutes, whereas a long test, you collect it after 24 hours. Now for Cushing's syndrome, you have the low-dose DEXA suppression test, right? So you give 1 milligram of dexamethasone at 10 p.m. and you collect the baseline sample at 9 a.m. in the morning. And first tablet of 1 milligram is again given at 9 a.m. For the next 48 hours, you give 0.5 mg orally. And on 3 at 9 a.m., you again check the level of cortisol. So a normal response, now since we are giving iatrogenically, we are giving exogenous steroids, the normal response would be suppression of adrenals. So the level of the hormones would be less than 50 nanomole per liter in normal case, correct? Now, if this is abnormal, then we go for high-dose DEXA suppression to basically localize where the disease is. So this differentiates between ACTH-dependent and ACTH-independent cases. So you give, this is high-dose DEXA suppression with a dose of 8 milligram of dexamethasone at night, and you collect the baseline sample at 9 a.m. Now you know if the cortisol is low, you have Cushing's disease. If you have a cortisol which is high plus ACTH low, you have Cushing's syndrome. And if they are both high, this is ectopic ACTH. Okay, so don't confuse yourself. All you have to remember is it is used to differentiate between whether it is ACTH dependent or independent. But when given a choice in your SPA to pick for one test that is used for Cushing's syndrome, you will go for low dose DEXA suppression test. Now, Addisonian crisis is one condition that you have to know. It can come as a clinical case scenario. So we saw that it presents with acute hypotension and shock. So how do you treat it? You gain an urgent IV access. You supplement the patient first by restoring the intravascular volume with sodium chloride. And after the bolus of sodium chloride is given, you supplement the patient with dextrose. 100 milligram of hydrocortisone is usually the starting dose, which is followed by 100 to 200 milligram over 24 hours. And always extra doses will be required in case of any surgery, any intercurrent illness, or prior to any exercise. Now, fludrocortisone is also given at a dose of 100 to 150 micrograms per day. And all the patients of Addison's disease have to be educated regarding certain points. First, they have to wear an emergency medical alert bracelet. They have to either double or triple the dose during cases of common cold or any tooth extractions. If there is any illness, they have to contact their general practitioner or the emergency department because we know they can't handle any infections or any stressful situations. Plus, you have to provide them with parenteral injections. They have to be trained for intramuscular injections in case they are unable to take their oral doses, like in case of severe vomiting or diarrhea. Plus, if you're giving mineralocorticoid, the dosage remains the same. You do not have to increase it in times of stress because hydrocortisone at a dose of 100 milligram itself has some mineralocorticoid action. So the dose of mineralocorticoid does not have to be increased. Now, next is primary aldosteronism. It is also called as Conn syndrome. Please remember this. Usually the question is framed as primary hyperaldosteronism, but it could be a new question in your RCOG exams. So don't forget Conn syndrome. So again, in hyperaldosteronism, you'll see sodium retention. So along with sodium retention, there's going to be water retention that can lead to hypertension. You'll have potassium loss, so hypokalemia. And because of sodium retention, water retention, there'll be suppression of RAS, right? Now, this hypertension is resistant or refractory. So diagnosis for this condition is renin-aldosterone ratio will be altered, or you do a saline or fludrocortisone suppression test. You don't have to go into the details of these tests. You just have to remember the diagnostic tests for each condition. So these conditions are mostly either because of adenomas, or it could be idiopathic or familial. Now, treatment, if in case it's an adenoma, it's a tumor, you have to go for surgical adrenalectomy. But if it's hyperplasia, you have to avoid it in case of bilateral hyperplasia, and you then prefer medical management in this case, correct? So medical management is spironolactone, and the specific one or selective antagonist for aldosterone is eplerenone, because we know in males spironolactone can cause some estrogenic side effects like gynecomastia. So more specific or more selective is eplerenone. Now, glucocorticoids can also be used for treatment for Conn syndrome, but only in familial cases. Certain familial cases are glucocorticoid sensitive. So glucocorticoids in very low doses may be used for primary aldosteronism. But the mainstay of treatment is surgical adrenalectomy as well as management by spironolactone or eplerenone. Now, congenital adrenal hyperplasia. This condition is basically autosomal recessive, and because of deficiency of enzymes. I find that there's a lot of confusion about this condition and a lot of doubts with regards to the enzymes. So just remember the most common form. In the RCOG, at the most, they'll ask you the first most common or the second most common, which was recently asked. So most common form is 21-hydroxylase deficiency, which is through cytochrome P21A, which is easy to remember, 21A. And the second most common is 11-beta hydroxylase. So these two enzymes are deficient. Now, presentation in females, you will have classic virilizing. Patient, a newborn baby, will present with ambiguous genitalia. In simple, this is also associated with a very severe salt wasting crisis. Okay. Now, simple virilizing is basically precocious. Patient presents later in life. This is a milder form of a 21-hydroxylase deficiency, and patient will present with precocious puberty. There will be clitoromegaly, and there'll be increased growth. There'll be accelerated growth, skeletal maturation. In the non-classical forms, you will have a patient, an adult who presents with oligomenorrhea, hirsutism, or directly when the patient comes to you for a workup for infertility. In the classic salt wasting, which is seen in very severe cases, you will have a newborn presenting in 1 to 4 weeks with failure to thrive, vomiting, biochemical abnormalities, and shock, and may lead to death. Now, this diagram shows you the enzyme pathway. So don't get intimidated by this. We don't have to remember all the compounds or all the biochemical processes. Just remember that 21-hydroxylase is deficient. So the byproducts of aldosterone and cortisol are not being formed here. So this pathway is not occurring, correct? So you'll have an increase in the precursors. You'll have an increase in progesterone. You'll have an increase in 17-hydroxyprogesterone. But aldosterone and cortisol are not there. So you will have all of the features which are basically deficiencies of aldosterone as well as cortisol, correct? And in this case, all of them are diverted to the formation of androgens. So you have increase in DHEA, androstenedione, and testosterone. Okay. Now, one peculiar thing that you have to remember, in case of 21-hydroxylase deficiency, we are expecting no aldosterone and no cortisol. So patient will present to you with hypotension, correct? Because there is going to be loss of sodium, there's going to be loss of water. But in a very rare form, in cases of 11-beta hydroxylase deficiency, you can have patients who are presenting with hypertension. Why? Because in 11-beta hydroxylase deficiency, this pathway is affected, but you still have the precursors of deoxycorticosterone as well as 11-deoxycortisol. Now, these do still retain some of the mineralocorticoid function and glucocorticoid function. So you can have patients who present with hypertension. So this may be one of your questions in case they ask you congenital adrenal deficiency. So 11-beta hydroxylase deficiency can lead to hypertension in contrast to 21-hydroxylase deficiency. Now, for diagnosis, we saw the precursors will be raised. 17-hydroxyprogesterone levels more than 1000 nanogram per ml are almost diagnostic. There will be high 11-deoxycortisol and deoxycorticosterone in 11-beta hydroxylase deficiency. Again, we saw low serum aldosterone level. So there'll be increase in the plasma renin activity. There'll be decrease in the cortisol. So again, there'll be increase in the ACTH production. Additional tests when you're evaluating a newborn, you would like to do an ultrasonography to look at any renal anomalies, or if there is coexistent uterine anomaly. You want to do a bone age study in case there is an accelerated feature of accelerated growth, as well as karyotyping of a fetus with ambiguous genitalia. Now, treatment, in vivo treatment with steroids, it is still in an experimental stage. It can prevent the virilization of a female fetus if the diagnosis is done in the antenatal period. So for a patient presenting with a salt wasting crisis, again, the treatment will be intravenous sodium chloride, again, supplement with dextrose. You supplement with everything that is deficient, basically. So you give dextrose, you give glucocorticoids, you give mineralocorticoids, as well as this patient will require long-term replacement. Now, corrective surgery in case of a female baby, because of clitoromegaly, you can do an early clitoral recession with a vaginoplasty, which is done after puberty. Basically, when the female adult genitalia form, that is when you can go for a corrective vaginoplasty. But this is only limited to cases which are severely virilized. You will not be doing this for milder forms, which can get corrected by glucocorticoid as well as mineralocorticoid supplementation. So in severe cases, we'll be doing clitoral resection of vaginoplasty. We have to make sure these are single stage repairs, as we're operating on a newborn or a baby. So it has to be a single stage genital repair. It has to be done by experienced surgeons. Now, pheochromocytoma. So now we've covered all the disorders which arise out of the adrenal cortex. Now, because of catecholamine problems, whatever other conditions, we'll be covering them now. So mainly the most important one you have to remember is pheochromocytoma. It's basically a tumor of a chromophil cells in the adrenal medulla. It has red proto-oncogene mutation. And it's important to remember that is a part of multiple endocrine neoplasia type 2, which is also called as Wermer syndrome. It's also associated with neurofibromatosis, especially type 1. Now, there is a rule of 10 of pheochromocytoma. Does anyone remember this? Anyone can type also in the chat box. Rule of 10. Okay. So just remember, for pheochromocytoma, 10% of these will be extra-abdominal. So we know these are arising out of the adrenal medulla, but 10% will be extra-abdominal. 10% will be bilateral. 10% will be malignant. 10% will occur in children. But 30% is what you have to remember are either syndromic or they are genetic. So when we mean by syndromic or genetic, we're talking about either part of MEN2 or neurofibromatosis. Okay. Now, a recently asked question is how do you diagnose pheochromocytoma and the child of pheochromocytoma? So I remember it as the initial PHE. So P is palpitations, H is headache, E is episodic spetting, which is hyperhidrosis. So pheochromocytoma is basically because of increased catecholamines, right? So catecholamine excess. So whatever conditions or whatever effects that you see in fight, flight, or fear, all of these will be exaggerated. Okay, so remember your worst condition or your worst fearsome situation, and whatever symptoms that you can think of will fall into this picture of pheochromocytoma. Correct? So you have a hypertension which develops over here. This is called as endocrine or a secondary hypertension. Correct? Now we just go through the clinical features first, and then we'll discuss the diagnosis. So again, you have headaches, you have sweating attacks, you have panic attacks, palpitations, tachycardia. Okay, you have hypertension that can either be sustained. This is when we're talking about hypertension, we're talking about mainly increase in systolic blood pressure. Then you have anxiety, pallor, nausea, abdominal pain, weight loss, paradoxical response to antihypertensive drugs, orthostatic hypertension. There can be dilated cardiomyopathy, elevated blood sugar, hypercalcemia. So diagnosis for this condition, in the blood, you will find increased levels of free metanephrine. Now, when we were studying catecholamine synthesis, we saw that norepinephrine and epinephrine were converted into their congeners. So these are the byproducts, or these are the products which are formed after chemical breakdown. So you have metanephrine, which has elevated free level in blood, and VMA, which is vanillyl mandelic acid, which is again a byproduct of the catecholamine pathway. But this is not very reliable in urine because this condition can also be increased in insulin-dependent diabetes mellitus. So whenever you have a question for pheochromocytoma and you want to diagnose it, please pick this option: elevated levels of free metanephrine or norepinephrine in blood. Now treatment, since it's an adenoma, it's a tumor which is in the adrenal medulla, the definitive treatment is surgery. Now during surgery, what has to be taken care of is intraoperatively, how do you manage the blood pressure as well as how do you manage the cardiovascular status. So intraoperatively first, always give alpha blocker. Can anyone tell me why? Something we studied back in our medical school. Pheochromocytoma. What happens if I give a selective beta?
We cannot give beta blocker because beta blocker can lead to breathing problem, and also cardiac output will get reduced. So
yeah, so what happens basically in pheochromocytoma, you have always the effect of beta 2. What does beta 2 do? Vasodilatation, correct?
Yeah.
So if you're only using beta blockade, what can happen is there'll be excessive alpha discharge. So this alpha sympathetic discharge will lead to excessive vasoconstriction, and patient will end up in a cardiac arrhythmia, may end up in a cardiac crisis on table. So always you have to give an alpha blocker and then you go for an alpha and beta blocker. You avoid selective beta blockers in case of pheochromocytoma. So we'll discuss a few questions which I have put up here from all of the conditions that we've discussed. Most of the questions are based on your clinical scenarios, but they do ask you questions with regards to the tests as well as hormones secreted from which part of the adrenal gland. So anyone wants to read this can unmute their mic and read this. Anyone can volunteer. We're all learning, so it's okay to make any mistakes. Go ahead.
Which of
Yeah. Go ahead.
Yeah, so which of the following is the most reliable test for diagnosis of Cushing syndrome? Option A is 24 hours urine cortisol. B is cortisol at 6 p.m. C is the dexamethasone suppression test. And D is serum cortisol. E is short ACTH suppression test. Is it a short ACTH suppression test or dexamethasone suppression test? I'm got a
Yeah.
bit confused.
So going back to the table, if you'd like me to.
Oh yeah, dexam.
Okay. So all you have to remember is 9 AM cortisol and synactin test. These are for insufficiency. And whenever we're diagnosing Cushing syndrome, the test of choice is low dose DEXA suppression. Okay. Yeah. So whenever you're solving an SPA, what I would recommend is when you read the question, think of the answer, make up your answer in your mind before you look at the options. Then check the options for the correct answer. Because if you do read all the options first before even thinking of solving the question, you tend to get confused, correct? So here, the best option amongst these is dexamethasone suppression test, which is more reliable. Okay. Next.
Just a glomerulus.
Take a guess. Or you can eliminate the options. If you start eliminating the options, you have clarity.
Arterioles,
Sorry.
afferent arterioles in kidney. Afferent arterioles in kidney. Afferent or efferent? So either I think afferent arterioles in kidney.
Anyone else? You're right. So renin-angiotensin system, we discussed about the release of renin, right? So renin is released from juxtaglomerular cells, and these are specialized cells which are located in the afferent arteriole in the kidney. So proximal convoluted tubule and ascending limb, collecting duct, these are all just distractors. All you have to pick is between afferent and efferent, correct? So answer is A. Juxtaglomerular cells is made up of JG cells, macula densa, and Lassus cells, and these are located in the afferent arteriole in the kidney. Next. Anyone? Someone else? Anyone can unmute themselves and talk.
Which of the following disorders is correctly matched to an appropriate diagnostic test? A. Addison's pseudocortisone. B. Cushing's synesthete. C. Addison DEXA suppression test. D. Cons saline suppression test. E. Cons 24 hours urinary cortisol.
Answer is B, Cushing synapse.
Again, we go back to the table. So even if you don't know the answer, I think by exclusion, you all should be able to solve it. Just remember this table. So for insufficiency, that is basically Addison's disease or Addisonian crisis, you just have two tests. 9 AM cortisol, which is your test of choice. And then if 100 to 400 is the value that you obtain, basically your diagnosis is not confirmed by 9 AM cortisol, then you go for a synaptin test. For Cushing syndrome, the first test you do is a low-dose DEXA suppression. It is the test of choice. And once you diagnose Cushing's, to know if it is a syndrome or if it is a disease, to differentiate between that, whether it is ACTH dependent or ACTH independent, is when you choose high-dose DEXA suppression test. So the only place where you will pick high-dose DEXA suppression is when you want to differentiate between these two. So your test of choice for Cushing syndrome becomes low-dose DEXA suppression. So even, so once you eliminate the options as well, even if you don't know the answer, as such, you should be able to. Yeah.
Addison's. It's Cons 24 hours.
So in Cons, you have a salt suppression test, which is synonymous to saline suppression test, which is used for Cons syndrome, which is primary hyperaldosteronism. So answer is D, correct? So for Cons syndrome, you have three tests. Either it is renin or aldosterone ratio. It is a saline or salt. Saline suppression test is used interchangeably as salt suppression test and fludrocortisone suppression test. Next one. One student, they can just unmute themselves and read the question. Someone who has not read it till now.
A 42 years old woman in clinic mentions she has been sweating and has frequent headaches. On examination, you notice her BP is 196 by 105 millimeter of mercury and pulse rate is 110 per minute. Which of the following conditions is not associated with the diagnosis? MAN 1, MAN 2, paraganglioma syndrome type 3, VHL disease, NF1. VHL?
Okay, so which is the disease in question? What's your clinical diagnosis?
Pheochromocytoma.
Correct, it's pheochromocytoma, right? So even if we don't know the conditions, we know specifically it is associated with MEN2, correct? Then there are other conditions like neurofibromatosis 1. Okay, it is related to VHL as well as paragangliomas, but not to MEN1. So MEN2 is Wermer syndrome, which is seen in association, basically extra abdominal pheochromocytomas, correct? So here the answer is A. The conditions that are associated with pheochromocytoma, they are MEN2, neurofibromatosis 1, paragangliomas, which are type 1, 3, and 4, and von Hippel-Lindau. So these are the four conditions where you will see pheochromocytoma, out of which paragangliomas are basically the extra abdominal pheochromocytomas that we see. Last question.
You are asked to give a patient with adrenal insufficiency.
Just read the question carefully and try and understand what they're trying to ask you.
Secondary adrenal insufficiency.
Yes, your answer is?
Answer is D. Waterhouse.
E. Primary hypertension.
Yes, anyone?
ARE.
Is it C, dysgenesis, adrenal dysgenesis? Because there won't be any
No.
release of
No.
A,
mineralocorticoid.
primary adrenal
ARD.
insufficiency.
ARD,
See,
yes.
I'll just remember this one point. Any condition which is affecting the adrenal, which is causing an adrenal insufficiency, is primary. Correct? So the defect is at the level of the adrenals,
Okay.
which is causing a deficient glucocorticoid or mineralocorticoid. Correct? So you will have an increased response to ACTH. So primary adrenal insufficiency, autoimmune adrenalitis, adrenal dysgenesis, all of these are affecting the adrenal gland. So all of them do cause primary adrenal insufficiency. Only difference is the Addison's is a chronic condition. Now, what is Waterhouse-Friderichsen syndrome? If anyone recalls from
After BPH,
microbiology, perhaps.
bleeding.
Waterhouse-Friderichsen syndrome.
After BPH, hemorrhage, excessive bleeding.
There's adrenal hemorrhage, correct. So there is adrenal
Mm.
hemorrhage. It has links to microorganism called Neisseria meningitis. This is another probable exam question that you should know. Adrenal hemorrhage, which occurs because of infection with Neisseria, correct. So this is an acute adrenal hemorrhage. This is again leading to a primary adrenal insufficiency. So all of these conditions will have decrease in the level of cortisol. So anything which is decreasing the level of glucocorticoids will lead to a feedback loop. And again, from the circadian rhythm, you'll have an increased level of ACTH secretion, correct? But in secondary adrenal insufficiency, the defect is the level of pituitary. So you will not have an increase in ACTH. So as we know, ACTH has some properties which are analogous or synonymous with melanocyte stimulating hormone. We find hyperpigmentation all the cases of primary adrenal insufficiency, correct? So E is the correct answer here. Secondary as well as tertiary. Tertiary will be at the level of the hypothalamus. These conditions have low ACTH as well as low levels of steroids. So that's all for today. Any questions? You can please ask. And let me know your feedback if this presentation was of any benefit, whether you gained some insight for your MRCOG preparation.
Yeah, it was very much academic. Plus, we have the basic concept, so we can when we will read it ourselves, it will be very helpful. And especially the pictures were very cool, or that was very well, beautifully explained in that picture.
Yeah, so that will be easier to remember because the data is so vast to remember. So you have to find ways to simplify it for yourself, either by mnemonics or pictures, or try to correlate everything. Here in this presentation, I tried to make it in a way that you can correlate it with your clinical scenarios. So there are certain buzzwords which they'll always post in your questions, and it'll be easy for you to pick up.
Thank you.
I have one request. I am Hina from Pakistan. I joined session very late. In
Okay, no
question
problem.
answer session. Can I get the recording of the session?
I guess it will be shared for you on the platform. We'll let you know on the group.
Okay. Thank you.
You all have any doubts about your preparation? Anything to do with your syllabus or?
Thank you so much. Thank you so much, Dr. John. I'm joining from Nigeria. Due to time difference, I tend to join very late. However, the session has been very wonderful. Thank you.
Thank you. Thank you.
Nicely explained, Dr. Sarah. Thanks a lot. And it was quite representative, the diagrams and easy to memorize. Thanks a lot.
You're welcome. I hope it has been beneficial, and this is how you should be studying all your topics, be it anatomy or pharmacology or microbiology. Try not to muck things up because at the end, there is so much to remember. So try to make everything concise so that you can have repeated revisions and keep practicing. So you will keep learning from MCQs because once we learn something, we have to apply it to the questions. And most of the SBAs are straightforward, but few, like we just saw, can be tricky, correct? So we have to know and try to correlate all the subjects. So it's everything together, right? That's the RCOG pattern of questions. So I'm very pleased to inform you that we are launching our MRCOG Part 1 course. It's a long course for January 2025. Dr. Shaista, Bilal and myself, we are both the mentors for MRCOG Part 1. And the course is starting from 15th August 2024. So We urge you to make the utmost use of it and join the course, where you'll have very well, highly resourceful guidance in the form of live recordings, live discussions, as well as we've curated all the data from all the high yield sources. So that is all you have to study, and then obviously prepare alongside by giving your mock exams, participate in daily discussions. And we're looking forward to conduct this course with you. So this is how the course we have laid out. We have the topics, and then we have ample time to devote to revision. Along with that, we'll have daily discussions on the previous topics, so you stay in the loop, correct? And you'll have mock revisions, and you'll have a final grand mock exam before the exam to prepare you for the final day. So do let us know if you need any guidance or if you need more information. You can contact us on, and I'll post your doubts on the WhatsApp as well as the Telegram group. Yes? So thank you, everyone. I'll sign off here, and we'll meet for more discussions on the WhatsApp group, daily discussions, wherein I post questions and related to your modules, and you can answer them, and we have an interactive session. Thank you.